Welcome, and thank you so much for joining this virtual session of advancing equity through innovative programs focused on at-risk infants, toddlers, and their families. We're honored to have been selected as part of this year's virtual AMCHP program, and we really regret that we could not connect in person. My name is Lindley Tanner Stapleton. I'm a public health analyst and project officer within the Division of Home Visiting and Early Childhood Systems in HRSA's Maternal and Child Health Bureau. The structure of our session includes three main sections. I will open by providing some context from MCHB's perspective regarding our early childhood work and opportunities that we see for advancing equity through new and innovative approaches to programming and service delivery. You'll then hear from Dr. Rahil Briggs and Dr. Jennifer Goldman-Frazier, both of 0 to 3, about the HealthySteps approach, which is anchored in the pediatric setting, and the Infant-Toddler Court Program, which is anchored in the court and child welfare systems. There are two specific examples of innovative programs that bring these approaches to life. And finally, we'll close with some individual reflection questions and opportunities for interactive Q&A through the portal at the end. I expect you all are familiar with MCHB's mission to improve the health and well-being of America's mothers, children, and families. Within the Division of Home Visiting and Early Childhood Systems, we focus this commitment on supporting pregnant women and our country's youngest children toward achieving a vision of creating communities in which all families can thrive and support their children to be healthy, nurtured, and ready to learn and succeed. This emphasis on all families is especially important in today's climate of glaring health and social inequities related to race and other demographic factors. Now, our investments seek to promote an upstream, two-generation prevention approach that focuses on the myriad of cross-cutting factors that affect child and family health and well-being. And these approaches better enable us to achieve long-lasting, long-term effects and to recognize and respond to the ways in which the needs of individual family members influence and are influenced by others in the family. The Division of Home Visiting and Early Childhood Systems delivers this through complementary programming of evidence-based home visiting, MIECHV, and a growing broader early childhood systems portfolio. And it's within this portfolio that we're proud to support the Infant-Toddler Court Program through a cooperative agreement, and we view HealthySteps as closely aligned. The Early Childhood Systems initiatives represent important systems building and strengthening efforts that bring the science of early development to national, state, and local systems by supporting the processes, strategies, policies, partnerships, and other infrastructure that's required to systematically improve the lives of families and communities for generations. By moving from program to place and building on existing assets and addressing localized needs, focusing on upstream approaches to accelerate population impact, building collective impact around early development and supports focused on cross-sector coordination and alignment, such as between health and early learning. And there's also a strong emphasis on using data and evaluation to guide our programming and centralized learning generation and dissemination. And we really believe that this type of support for infrastructure, partnerships, collective impact approaches, policy development, integration of two-generation evidence-based and promising approaches across and within sectors, developing systems for early identification of risk, and developmental promotion efforts, alongside a guiding central framework of advancing health equity, are critical to achieve the population health and developmental outcomes. And I'm really excited that representatives from both HealthySteps and the Infant-Toddler Court Program will get a chance to speak to you about their work because they both really align closely with the goals of our portfolio and represent innovative models for addressing challenging yet common problems in the public health space. They reflect and build on a public health model of a continuum of services that starts with broadly based preventive interventions to minimize the number of individuals and families that require more intensive care and supports. And some features that I'd like you to note as you listen include the emphasis on infants and young children to maximize that upstream impact, engaging underserved or what some might consider hard to reach populations, particularly those with a high level of complex service needs related to significant trauma and or substance use histories, with a real focus on equity, family-centered care, and early identification of need and access to services. Alongside that, there's an explicit attention to social determinants of health and care coordination. Really thinking about moving beyond only direct service delivery to really change the systems that surround care and forging robust cross-sector partnerships. As I said, my colleagues will present more details about each program and how they're putting these concepts together and principles into practice, and how the broader MCH community can engage and partner in this work. And as you listen to the presentations, I invite you to think about how these questions that are on the screen and how the approaches that are presented today might make a difference in providing mothers, children, and families in your states and communities with quality care. So as you listen, think about some difficult cases that you might have come across, what made them challenging, what you wish might have gone differently, or what other resources or supports might have been helpful to you and or the family in changing the outcome. And also think about what segments of your states or communities might not be effectively reached and who might be missing or left out that these types of approaches might advance. So now I'll turn it over to Dr. Raheel Briggs, the National Director of HealthySteps at 0 to 3, to provide an overview of the HealthySteps approach and how they're tackling these important issues.
Thank you so much, Dr. Tanner Stapleton. I was seriously scribbling down notes frantically as you were talking, thinking about so many areas of alignment, whether it be equity or population-based health or two-generation care. So I am thrilled to just jump right in and talk with you today about HealthySteps. It's my pleasure to be part of this presentation. Thank you to AMCHP, and pleasure to be part of this AMCHP community. Wish we were all in person. I'll spend the next 15 or so minutes talking about HealthySteps, a program of 0 to 3. So what is HealthySteps? Well, at its very base, it's the operationalizing of team-based care for babies, toddlers, and their families. We are an evidence-based program with a national RCT and multiple subsequent site-level investigations. Interdisciplinary because, like I said, team-based. We're adding a new team member to the primary care practice, which is really exciting. And those HealthySteps specialists, the new team member, who are most often a licensed clinical social worker, another master's level provider, or a child psychologist with specific expertise in early childhood development and early childhood mental health, are integrated into that pediatric team, and they provide a risk stratified series of interventions. There's short-term behavior and development consultation. There's referrals to needed services outside of those four walls of the pediatric practice. We know we can't solve everything inside. And then more intensive services when needed for our most at-risk families. A couple of notes here. Number one, just for definitions, when I say pediatrics, I'm talking family medicine, I'm talking pediatric nurse practitioners, really anybody who's providing that well child care to children and their families. And number two, just wanted to highlight that in the midst of the very reason that we are all virtual, the COVID-19 epidemic, interestingly enough, the American Academy of Pediatrics came out at the very beginning saying that it was critically important that pediatric well visits for infants and toddlers ages birth to 2 continue to be held in person. And this is important for a whole host of reasons that I won't go into today. But as we think about the enormous disruption to all of our lives, to our loved ones' lives, and to our community and to our world, interestingly enough, pediatric well visits have continued. They're that important to provide that in-person care. We've even heard from some of our HealthySteps sites around the country that their system was contemplating moving to drive-through visits or the like, but stayed in person largely because of that AAP guidance and because of how important it was that their HealthySteps specialists continue to see families in this time of really increased needs. So why pediatrics? Well, for those of you who aren't fortunate enough to have spent time with pediatricians, they're some of the best people, or in the pediatric setting, it's been my great pleasure to spend my entire career, really, after a first couple of years in the mental health service system, wondering how to reach families earlier and reach families faster, and I landed in pediatrics. So when we think about this setting, Dr. Tanner Stapleton mentioned how we think about those harder to reach families. those families that aren't necessarily coming to center-based programs or showing up where you'd hope they would. Interestingly enough, depending on the data set that you look at, 90 to 95% of families with very young children regularly attend that pediatric visit. It's the one system we have that can universally reach families. And so for me as a child psychologist coming from that children's mental health system, it was like, what is this unicorn? How have I been not partnering with these folks all along? So access, discussed, trust. You want to talk stigma and trust from the mental health system, I can tell you some stories. You know, families don't bring toddlers to see psychologists unless things have gotten really quite bad. But they bring babies and toddlers to see pediatricians all the time. It's an enormously, not just non-stigmatized system, but positively stigmatized system. And depending on any data set you look at or recent surveys, parents often talk about who they trust for information about their young children. And once you get out of the immediate family, pediatricians are right there at the top of the list. So we're really leveraging this opportunity and leveraging this platform by adding in that HealthySteps Specialist. You see one of our best on the screen right now, Dominique. So why do this though? Well, because pediatricians have usually about 15 minutes to do a well child visit. And in that 15 minutes, they're supposed to do everything under the sun, from, you know, talk vaccinations to bicycle helmets to fluoride to check to see if the child's actually growing. And then you say, okay, and now look at that parent-child relationship and think about toxic stress and think about adverse childhood experiences and maternal depression and social determinants of health. And they say, I've got a waiting room full of families. Not that they don't think it's important, but it's simply not allowable within that 15 minutes. Add the HealthySteps Specialist and you're doubling your capacity to really focus on those critically important things. So this is 2-generation, even multi-generation intervention, because the other beauty about pediatrics is they don't come there on the school bus. They don't come there by themselves. They come there with their caregiver. And finally, if you're all a little bit away from those moments of taking your infants and toddlers to the pediatrician, you may have forgotten that you're there pretty darn often, 7 times in the first year of life and 12 to 13 times in the first 3 years of life. So you've got this universally, almost universally accessed system, positively stigmatized, repeatedly accessed, and so deeply trusted in the most vulnerable parts and times of a family's life. And it's our honor to really partner with pediatricians. As I've mentioned, we have a tiered system of intervention that is both population-based at Tier 1 and risk stratified, going up through Tiers 2 and 3. So in Tier 1, every child and family in the practice birth to 3, and people can go before that prenatally and older than that, older ages, but we require birth to 3, receive a set of services. These are our first 3 core components out of 8. Children receive universal screening, including autism, behavior, development. Families receive universal screening, including annual looks at social determinants of health, and also early looks at perinatal mood disorders in terms of caregiver depression. And then follow up on those screens, because what good is a screen without follow-up? Moving up the tiers, you see that in Tier 2, we get to what we like to think about the lightest of pink flags. Not waiting until those bright red warning signs occur, not waiting until the child's been expelled from preschool or there's a massive other big problem, but looking for those lightest of pink flags. And for those children, we offer short-term behavior and development consultations, a real focus on care coordination and systems navigation. As I mentioned earlier, we're not living in some fantasy world where we think we can solve all the problems inside the pediatric practice. We rely very heavily on our partners in the early childhood system. Part C, early intervention, other early childhood education, early Head Start and Head Start, our child parent psychotherapy partners, and the like. But we also know that when you just give a referral from a pediatric practice, it often goes into the black hole of referrals, not successful. And so HealthySteps specialists, it's their job to make sure that referral is successful, and we ask them for those data. And then the sixth and seventh core components, are a real focus on positive parenting guidance and early learning resources, including STEM. This is a place where we really leverage the 0 to 3 platform in thinking and make sure to get these high quality tools and information into parents' hands. Finally, Tier 3. Tier 3 is for our most at-risk families. Remember, these are families with kids birth to 3, so at-risk is going to look very different depending on the community. We're in 22 states and almost 170 communities across the country right now. Far be it for us at the HealthySteps National Office to tell you what risk looks like in your community, but I bet you have a pretty good idea. Whether you're struggling with the opioid epidemic, or whether it's parents with very high adverse childhood experiences or ACEs scores, those might be some of the families that you offer Tier 3 services to. And for families in Tier 3, they receive everything in Tiers 1 and 2, plus the HealthySteps specialist co-manages each and every one of those well-child visits, preventively, prospectively, really establishing a trusting relationship with the family and being there as a really appreciated partner in this journey. So this next slide shows you those same 8 core components, just listed out, not tiered, but to give you a sense. These are the 8 core components that you must implement to call yourself HealthySteps. We give new sites 3 years to get up to fidelity. And they can do more above this. For example, many of our sites in Arizona also offer certified lactation consultant services because their HealthySteps specialists have become certified lactation consultants. Sites in New York offer parental mental health for that same thinking. The pediatrics one, no secret, that's where you find the parents. But these are the 8 required core components. I want to touch now on our evidence and really walk through how the evidence aligns with some of the stated objectives of the Maternal Child Health Bureau. So we have outcomes, we've divided our outcomes up into 8 areas, and these outcomes come largely from a national randomized control trial that served over 5,000 children across many states, with results featured in both JAMA and pediatrics, initial results and follow-up results respectively. We continue to have site level evidence as well, adding on to these areas. We have some outcome pilots right now where we're doing a deep dive into furthering our outcome and evidence base. Let me just focus on a couple here. So on parenting knowledge and practices, parents in the HealthySteps intervention group in the RCT were 22% less likely to rely on harsh punishment like yelling or spanking. On early literacy and school readiness, almost 90% of our sites are also Reach Out and Read sites, and we partner very closely. And moms were 22%, again 22%, more likely to show their children books every single day. And finally, when we think about child safety, in that RCT, we showed 23% fewer emergency room visits for children who received HealthySteps. I could go through each and every one of these outcome areas if we had more time. You can see all of this on the website at healthysteps.org, and happy to take questions about some of these outcomes as well. I wanted to move now into how these outcomes align with the Title V, both national performance measures and outcome metrics. So for NPMs, as we've talked about, this is a dyadic model, and we really cover a vast array of outcomes. So what we've done here is selected 5 of the national performance measures that you are all probably very familiar with. Those are in blue. For me, on the left side of the screen I'm looking at, but maybe on the right side for you, but in blue. And in green are specific outcomes from the HealthySteps RCT that we have achieved. So breastfeeding, safe sleep, developmental screening, hospitalization for injuries, and that real medical home. HealthySteps hits each and every one of those outcomes with very compelling RCT data. If we move into the national outcome measures, as you all know probably better than I do, these are really population level domains, really looking at maternal and child health population status. We are right in line with you on that population health model. I almost dropped out of graduate school for a minute about 25 years ago when I got frustrated with the idea of just serving one kid at a time. It seemed like there were too many families that could benefit. So we are so right there on that population health model. And we were also right there in terms of the data-driven legislative intent of these Title V and national outcome measures. We have systems in place where we actively monitor and support sites as they seek to hit fidelity. They need to hit it by 3 years. And each and every one of those 8 core components that I mentioned earlier has a fidelity metric or two tied to it that they have to hit. So for example, you must screen 90% of your kids for autism before age 2. So that's just an example. All sites report data to the national office annually, and a subset also are giving us data quarterly so we can do more rapid cycle innovations and understanding exactly what's going on. The national office has fidelity requirements not just on the service delivery side, but also on the outcome side for the whole national network. So again, all the data you're seeing here showing the national outcome measure on the left in blue, school readiness, autism, mental health treatment, postpartum depression, overall health status, and child immunizations, and then the HealthySteps outcomes in green. Really focusing on something that's been very important to all of us lately, discussions about well child visits and vaccinations. Of course, these RCT data are pre-COVID-19, but we have some emerging data that HealthySteps sites are continuing to make sure that their children come in for those well child visits and receive those very critically important vaccinations. So those 2 slides were RCT data, but I also don't want to neglect some of our emerging evidence from some site level research that's much more recent and hot off the presses. So we have some evidence that HealthySteps specialists are better able to ensure that kids get connected to dental care and oral health care earlier. We know that is such a cost driver for the system. Those kids who aren't showing up until 4 or 5, we're working on getting them connected much earlier. Caregiver smoking, again, this is a dyadic model. If you want to find parents, they're in the pediatrician's office. And so really focusing on caregiver smoking, making referrals, and having that discussion. And obesity, and you might say like, what? You didn't say this was an obesity prevention program. Not necessarily, but it is a parent-child relationship program. And the more that we learn from the evidence and just from our guts, quite frankly, the more you can impact that parent-child relationship, those outcomes spread far and wide because so much really starts there. So I want to close by just letting you know that we have grown almost entirely organically, meaning sites come to us with the interest, the money, the hired person, by 23% over the last 2 years. While COVID-19 has certainly put a pause on this, it's put a pause on our onboarding, we have transitioned to virtual onboarding, and we just brought on board 2 sites virtually through a virtual training last month. They were Department of Defense sites in Hawaii. Our luck that our first virtual training is in Hawaii, but there we are. We have found that all the sites in the pipeline to implement HealthySteps before COVID are still there. No one's backed out. And in many instances, we are hearing loud messages that say HealthySteps now more than ever. Because quite frankly, families have more needs. We're seeing families who have basic resource needs who never had them before. We're seeing children who have developmental needs and mental health needs. And so our HealthySteps specialists have been out there on the front lines, getting diapers into families' hands, providing mental health services and referrals when needed, and really reaching children and families in that pediatric platform. Our goal is to serve over 1 million children annually by 2032, with a big focus on children with Medicaid and CHIP, and children in those communities that don't often get the resources. We are very committed to the equity message of our work. When we look at things like breastfeeding rates, early intervention successful referral rates, obesity rates, and the way those data tend to really cut, if you will, alongside racial, ethnic, and poverty lines, we're committed to changing those outcomes for families. So I look forward to chatting with you all during the question and answer time, but it is now my great pleasure to introduce my colleague at 0 to 3, Dr. Jennifer Goldman-Fraser, who will talk about the National Infant-Toddler Court Program. Jennifer?
Thank you, Raheel. I am so delighted to be introducing the work of the Infant-Toddler Court Program alongside HealthySteps. Our program is another national platform for addressing the developmental needs of very young children and strengthening their families. However, our focus is on supporting one of the most difficult to reach populations, children and families who become involved with the child welfare system. And we do this with an innovation known as Infant-Toddler Court Teams. By way of introduction, I'm a research developmental psychologist with an MPH in maternal and child health. And here at the Infant-Toddler Court Program, my work focuses on research planning to build the evidence for infant-toddler court teams. And prior to joining 0 to 3, I had been engaged in a statewide initiative to build a more trauma-informed child welfare system in Massachusetts, where I am located. I also previously led a CDC-funded research study examining effective dissemination strategies for replicating an infant-toddler court team in new communities. Next slide, please. Infants and toddlers have the unique and urgent developmental need for safe, stable, and nurturing caregiving. And yet it is this very age group that is most likely to experience disruption and disturbance in the caregiving relationship. And as you can see in these data, children aged birth to 3 have the highest maltreatment rates and the highest rates of removal from the home and placement in foster care. And across all age groups, including infants and toddlers, children and families of color are overrepresented in the child welfare system and less likely to receive the services they need. Unfortunately, young children's developmental needs are minimally addressed in standard child welfare and court policies and practices. Next slide. And so this is where the Infant-Toddler Court Program comes in, with an overarching goal of improving the health, well-being, and development of infants, toddlers, and their families in the child welfare system. The program is supported by the Division of Home Visiting and Early Childhood Systems within HRSA's Maternal and Child Health Bureau, where it sits alongside a number of other systems integration and systems improvement programs. This work was previously supported by the Administration for Children and Families Children's Bureau, and then transferred to HRSA in 2018, and is currently funded through 2021. The program serves children in foster care and their families, and also serves children at risk of removal from the home and placement in foster care. So these child welfare cases are under the protection and supervision of the court. Like HealthySteps, the National Resource Center for the Infant-Toddler Court Program is housed at the organization 0 to 3, where it serves as a hub of expertise on the developmental needs of infants and toddlers, and on ways to support the earliest caregiving relationships in the lives of young children, relationships that lay the foundation for lifelong health and well-being. The program's central work is focused on supporting the spread of infant-toddler court teams across the country, and this work is informed by the Safe Babies Court Team approach, which offers communities a structure for improving systems and increasing linkages and alignment across early childhood systems for children and families who are involved with the child welfare system. Across the past 15 years, a number of evaluation and research studies have been conducted on the Safe Babies Court Team approach, as well as related infant-toddler court teams that were inspired by the approach. This growing body of evidence has consistently demonstrated the benefits of infant-toddler court teams across a range of outcomes, including increased linkage to developmental health and mental health services and supports for both children and families. Next slide. So infant-toddler court teams function as a vehicle for driving improvement in 5 strategic areas. The first area is interdisciplinary proactive teamwork. And this is about professionals coming together across sectors and systems, led by judicial and child welfare agency champions, to collaborate in changing their usual way of doing business. This cross-disciplinary collaboration efficiently and effectively identifies systems gaps, and because it involves decision makers, leads to needed changes in practices, in procedures, and in policies. The second area is enhanced oversight and collaborative problem solving. So cases involving infants and toddlers must be closely monitored. In standard practice, court hearings are commonly 6 months apart or more. Parents are minimally supported to engage in the services required in their case plans, and children's developmental issues are commonly missed. Infant-toddler court teams ensure that hearings are more frequent, that families are engaged and empowered to succeed in meeting the goals of their case plan, and that children's developmental needs are identified and met as early as possible and monitored throughout the case. The third strategic area is ensuring expedited, appropriate, effective services. And here the emphasis is on referring children and families for the systematic and timely identification of needs through screening and assessment. This area of focus also emphasizes referrals to evidence-based prevention and intervention services, including pediatric preventive health care and timely and effective mental health supports both for children and adults. So that includes infant and early childhood mental health services. And very importantly, it also emphasizes the critical need for comprehensive, concrete supports for parents and families that address basic needs such as housing and nutrition. The fourth strategic area is trauma responsive support. This is about ensuring that everyone involved with the case, everyone who is interacting with that child and family, is using a trauma lens. And what does this mean? One important change in practice is that the judge and all professionals create a compassionate, healing atmosphere, both inside the courtroom and during hearings, and in all interactions outside of hearings. It also means that all professionals involved with the case are really attuned to the very young child's trauma as a result of maltreatment. So everyone is attuned to make sure that children who have experienced neglect or abuse are not being further traumatized by additional disruptions in caregiving relationships, and that they receive infant and early childhood mental health services that will restore their sense of safety and trust and right their developmental course. Finally, the fifth strategic area is continuous quality improvement. And CQI is really the engine that drives effective uptake and sustainability of infant-toddler court teams. The Infant-Toddler Court Program manages a national database and provides support to local sites in collecting, entering, and using their data for CQI, and also to tell the story of their success to use their data in seeking funding. Next slide. Each of these areas of strategic focus that I just described is operationalized at 2 levels of action. At a direct service level, a team of professionals, the child welfare worker, attorney for the parent, attorney or advocate for the child, and service providers collaborate with the parent and other family members or sources of support on the case plan. This team cultivates a safe place for the parent where they feel respected, they feel genuinely supported. And in so doing, they're more likely to become engaged in needed services. A key member of this team, and a role that is unique to infant-toddler court teams, is a community coordinator. And in this role, the community coordinator engages in significant outreach to build a seamless continuum of care for both children and their families. And the community coordinator also supports the parent in navigating the service landscape. At the community level, infant-toddler court teams engage in partnership building and service alignment, invoking and involving a range of diverse stakeholders, including child welfare staff, attorneys, the public defender's office, primary health care providers, mental health and substance use professionals, early intervention specialists, home visitors, early learning and child care providers, and more. At both levels, the objectives are to strengthen and align systems, to promote the use of effective and comprehensive services, and to address racial equity. Next slide. This visual is helpful for seeing how the work of the Infant-Toddler Court Program reflects a public health approach. The program has a foundational focus on systems and capacity building that drives a robust continuum of comprehensive, coordinated, equitable services. Services that will reduce the number of children and families needing intensive care and supports further up the line, and ultimately can prevent the need for child welfare involvement in the first place. One particularly innovative aspect of this work is the breaking down of silos between traditional child welfare services and the broader array of early childhood systems. So for example, the program works to integrate home visiting and other prevention programs into that continuum of service for young children who are at risk of removal. The program is also working to integrate infant-toddler court teams into each community's early childhood system of care. Next slide. So briefly, I'll share some key outcomes from the most recent evaluation study of infant-toddler court teams. This slide presents findings from a cross-site evaluation of 10 sites around the country. The evaluation was conducted by RTI International between 2014 and 2018 with a sample of 251 children and their parents. A chief outcome of this work, of course, is prevention of repeat maltreatment. And you can see here that the rate of maltreatment recurrence in a 12-month period was only 0.7%. So this is substantially lower than the 12-month national standard or benchmark of 9.1% that's set by the Administration for Children and Families Children's Bureau for child welfare agencies across the United States. Other key outcomes for court teams are placement and permanency, which are indicators of the degree to which the young child's early caregiving relationships are protected and stable or disrupted. The evaluation found that the majority of children in the sample, nearly 80%, had 2 or fewer different placements while in foster care. And that's compared with the national standard of 66.1%. And the evaluation also found that nearly 84% of children were in a permanent home within 1 year. This is more than twice the national standard. Another very important finding from the evaluation was that 1/3 of children whose parents had the highest adverse childhood experiences, 30% of children whose parents had the highest ACE scores, ended up being reunified with their parents. And this really illuminated how with the right supports and services, the most complex needs can be met, protective factors can be built, and that the resilience of parents and families can be bolstered. And last, but perhaps most importantly, no differences were found by race or ethnicity for any outcomes in the evaluation, suggesting that infant-toddler court teams are a strong corrective against the racism and bias that leads to the disproportionality in foster care placements and disparities in access to needed services for children and families of color who become involved with the child welfare system. Next slide. On this slide, you can see more fine-grained outcomes on the positive impact on service linkages. The vast majority of children experienced high levels of needs identification, timely service referrals, and timely receipt of services. And again, there were no significant differences by race or by ethnicity. Next slide. Many target outcomes of the Infant-Toddler Court Program align with a number of national performance measures and national outcome measures. The ones listed here are areas where we have shown impact to date or are areas where we are increasing attention to in our work. I also want to point out that the population of children served by infant-toddler court teams meets the definition of children with special health care needs due to the elevated risk of developmental delays and disabilities associated with maltreatment exposure and related risk factors. Next slide. I'll just take another moment to point out the program's alignment with the maternal, infant, and early childhood home visiting program in terms of overlap with MCHB's priority populations and a number of MCHB performance measures. We see strong potential for increased collaboration between MCHB and infant-toddler court teams as an opportunity to mutually amplify impact and as presenting new possibilities for engaging families in needed services and supports. So developing strong connections with MCHB is an important area of work for the Infant-Toddler Court Program. Next slide. This map shows sites where the National Resource Center is supporting uptake of an infant-toddler court team or multiple teams. A darker shade of blue indicates that there's at least one court team site active in that state. Currently, there are 56 active sites working with the National Resource Center around the country. This includes 2 states that are engaged in statewide spread of infant-toddler court teams. Tennessee is one of those states with 12 sites, and Florida is the other state with 27 sites. We are also working with 42 additional communities across 22 states that are seeking the support of the National Resource Center in bringing an infant-toddler court team to their local jurisdiction. This includes working with 6 states that are exploring the possibility of implementing multiple court teams in their states. These are the light blue states. Overall, we estimate that the National Resource Center is currently reaching more than 1,500 children and their families each year. Currently, the program is engaged in significant expansion efforts to build state-level coordinating teams that will enable states to stand up multiple infant-toddler court team sites. This state-level work also involves building state advisory teams to build and sustain the vision for the work. These teams include the State Child Welfare Agency and other relevant state agencies, the State Administrative Office of the Court, judicial leaders, legislators, public health leaders, and early childhood advocates. In the next year, we'll be working to develop state teams in 3 new states. Those states have not been identified yet, but are currently being selected through a competitive process. Both in our own work and through the experience of HealthySteps, we know that increasing the number of sites in a state accelerates growth and sustainability statewide. And so now, moving from this big picture about our expansion work, I'd like to close by giving you an opportunity to hear the voice of a parent from one of our infant-toddler court team sites. So this video clip is from a set of online learning modules we developed for judges and attorneys, and that's why the screen looks like an e-learning dashboard. The parent, whose case was closed a number of years ago, is being interviewed by the person who was the community coordinator on her direct service team. You can hear in this brief clip how the hallmarks of infant-toddler court teams, those areas of strategic focus that I described earlier, made a critical difference for this mother and this family. Listen, and you'll hear her reference the collaborative approach, how she was connected to the services she needed, and how kind and compassionate support made her feel safe. And as you're listening, think also about that foundational work of systems and capacity building that was happening at the community level, which was essential for ensuring this mother had the timely access to the meaningful services that she needed.
Montana Guthrie, parent.
So can you tell me what brought you in contact with the child welfare system?
My children were removed from me in December 2014.
How are you feeling?
How was I feeling? Like I was ashamed, terrified, scared.
So what do you think the difference was in how they were when you got to court, the judges and the attorneys, compared to how you expected them to be?
There are people here to help you, and I thought I was just gonna be me, you know, like on my own. I didn't even know there was gonna be an attorney there for me, honestly, but you know, there was more people in that room there for me than there was pressing charges against me. So my first attorney, she was great. She pulled me back like a lot before court and sat down and like wanted to know what happened. Like, yeah, she had the black and white, but she wanted to know like my side of my story. And you know, I cried, she cried with me, and she was on my level. Like, I didn't feel belittled or anything, and she was just very compassionate. The first court hearing I went to, like I knew I'd messed up, obviously, because my kids were taken, but the judge had told me that I had the most well-behaved kids to ever enter foster care. And that made me like, she was like, so you've been doing something right, you just got off got off on the wrong track. That made me proud, even though I was sitting there because I'd messed up.
What did your team do that you thought was the most helpful to you?
It was always good, it always ended well. It always focused on me, what I needed to achieve, and how to help me get there. And I did.
And what was your safe space in that room?
You were always there.
Montana, as a parent going through this, what do you want the attorneys to know? Like, when they meet a mom like you that's in a position to need help from them, what do you want them to know?
That I know they see 1,000 people, but we are not all the same. Just because I don't know, some of us made the same mistakes, it's not going to have the same outcome. I'm not going to make the same mistakes someone else did. They're not going to do the same things I did. I'm not perfect. I gave every ounce that I had into this.
So valuable and important to hear directly from families. It helps keep front and center who we're serving, and the impact of the work is captured in a very, very real way. So finally, I'll leave you with a set of citations for research studies on the Safe Babies Court Team approach. We've also included here citations for related research that's been conducted on infant-toddler courts, each of which was inspired by and comprised components of the Safe Babies Court Team approach. So each has a common thread of judicial leadership, connecting children and their parents to infant and early childhood mental health services, enhanced service coordination, and cross-sector collaboration that keeps the baby or toddler at the center of all decision making. And so with that, I'll move back to Dr. Stapleton, who will provide some closing reflections and move us into the live Q&A. Thank you.
Okay, thank you so much, Jennifer and Rahil. Those were incredibly valuable and informative presentations, and I hope they sparked some curiosity and some interesting thoughts among our audience today. And I really hope that the audience agrees that we here at HRSA and MCHB, we see the clear opportunities for both these specific programmatic partnerships and collaboration between these two programs and our Title V and other MCH stakeholders. And we also see some really great opportunities for shared learning about practices and principles that can apply across programs and settings to achieve the MCHB mission of improving the health of America's mothers, children, and families. We really are excited about the evidence that suggests that by our adjusting our programming and partnerships toward these multi-level and cross-sector approaches and encouraging our individual programs to do so as well as by expanding our scope of what interventions are within the domain of public health to address and what we consider within the scope of public health. These approaches can reap some really significant benefit in terms of critical outcome measures of health and well-being, particularly among communities that currently experience the most adversity. Specifically, the data indicate that we can really do a great job and increase the engagement in preventive healthcare, both for children and parents, that we can increase the receipt of evidence-based services to address behavioral health and developmental needs, and we can make really remarkable and important improvements in child safety, child developmental trajectory, and family protective factors. So we'd like to invite some questions right now from the audience. We have the interactive Q&A portal up and really want you to think about, ask any questions that might be coming to mind, any things that excited you or that piqued your interest. We're particularly interested in knowing how you might be reaching current families with young children, particularly those of higher needs or who aren't effectively reached through your current operations, and what you might have learned or what you might be interested from the approaches that were presented today. Think through what your wish list of service linkages might be that you haven't been able to make, those particular barriers that come up in terms of getting access to all of the services that families need. And how you might bridge those connections through these types of approaches or programs. In addition, what you heard today that you might apply in your work. What things might you take back to your directors, your program leaders, your staff to see what adjustments can be made, what opportunities there might be for specific partnerships or collaboration to take it to the next level deeper. Again, we're really interested in what came to mind, what was interesting, and what might be done within these programs, within your programs or across them to really generate some improvements for children and families. And more generally, we invite any other questions, observations, shared strategies, things that we can learn from the work that might be happening within your universe of action. I'll flip forward to contact information for both of these programs if you have any other questions or inquiries. I know both programs are very interested in making connections with the AMCHP attendees today. And I'll put it back to the reflection slide, the question slide, for any additional Q&A that you want to send in. Thank you so much for listening, and we really appreciate your time.